Okay, doctors, let's get started. My name is Dr. Ataii, and we're going to talk about a little bit more technology, a little bit more about orthodontics for the general practice, and then we're going to talk how we incorporate using the Propel devices and how I am able to kind of navigate through clear aligner treatment and some of the cases that we've done. Now, some of the disclosures, obviously, as you know, I'm not employed by any company. However, I do participate in lecture and honorariums received for this broadcast. Also, some of you may already know and might have heard of me. I've been treating Invisalign patients for just about 10 years now, hitting well over cases that I can tell you from mild, moderate to some of the severe cases. And the challenge has always been, how do we get these patients into treatment and get them out of treatment within a year's time? Sometimes the question becomes predictability and case efficacy, and we start talking about navigating through restorative, as you see in a recent article that I had, and even getting into the world of sleep medicine. Orthodontics becomes a cornerstone of what I like to call correcting the malocclusions, and clear aligners definitely all have a place in my practice. And most importantly, how do I get the treatments done effectively, expeditiously, if you will, and most importantly, allow me to get home to my family. And as all of us know, those of you who are joining us at 5 o'clock after your hard day of practice, and I'm in California, some of you are in New York time, 3 hours ahead. How do we get these treatments completed so we can just have an easy life? We've got to get into understanding of tooth movement factors. And we have to get to a position where when you start talking about tooth movements, time, space, pressure, these are needed to move teeth. Whether you're talking about root movements, because that's definitely needed, or uprighting teeth, expanding arch. The important part is that we have to understand that in order for a practitioner to complete these tooth movements outside of the biology, it becomes patient dependent, practice dependent, and even now you got to take into the patient's biology, because that becomes beyond our control. So for instance, if you're practicing clear aligner movements and you gave a certain type of instruction to your patients, change your aligner every 2 weeks, change your aligner every week, change your aligner every 3 days. Guess what? If they don't follow that instruction, that becomes a problem. If they don't maintain their appointments, the integrity of the appliance, it doesn't matter what you've instructed them with, the patient is a dependent factor in tooth movements. And also the practitioner. You may not quite have the flexibility of using different types of treatment parameters. For instance, if the crowding on a lower arch is greater than 6 millimeters, what do we do about those? Do we use the same tools on every patient? Once we understand the basic factors, now we're going to get into a case selection protocol. So looking at someone like Catherine, as you can see, she has a class 3 lower bite that is coming together, but on the anterior, she's somewhat of an edge to edge. The laterals, which are the most difficult teeth that you can see, are always hard in moving them. And as I say, they get stuck between the big canine and the big central incisor root. We just got back from the Invisalign Summit, and those of you who have been, it was a pleasure seeing some of you that are probably online now. I'm pretty short. I'm just about 5'5", and I was standing next to 2 other speakers that were a little well over 6 feet. And both these speakers were talking about root movements, and we were talking about the subject of accelerated tooth movements and predictability. And one of the subjects that came was laterals. We have such a hard time moving laterals. What do we do? Well, think about this. You need time, space, pressure. We talked about the 3 factors of patient compliance, doctors picking maybe the right attachment, or maybe is this an Invisalign case at all? Is it a clear aligner case at all? And then we start talking about the biology. Well, that lateral is wedged between 2 large roots. If you look right now between tooth number 9, 10, and 11, these roots are going to have to make room for that lateral to extrude down, to potentially come into position. This patient is a skeletal problem where the lower mandible is forward. You can see in her jawline. Well, when you go through this patient's treatment planning, you talk to the patient about surgical options, you talk about the patient of wire and brackets, and the patient comes and says, look, I know all of my options. I just want a cosmetic solution. How can you make my front teeth look better? Well, okay, I don't know if I could get that lateral extruded in a good position. I don't know if I can get the anterior set up, even the social 6, I like to call it. I'd like to at least work on the bicuspids not having that traumatic edge-to-edge bite between 5 and number 29 opposing. So this conversation becomes a conversation which advanced or additional auxiliaries are needed in terms of using clear aligners, should you choose going with this case. Now, I introduced to you the idea, those of you who know already about MOPS or know about the idea of acceleration, to me, the word acceleration is not as important as predictability, allowing these roots for that lateral to fit in properly. And tracking is important. Looking at a case like this, the lower arch by itself and the upper arch by itself could potentially, you can procline some teeth forward, maybe expand upright some roots, and they could look great. But all you're doing is putting the patient in a bigger class 3 occlusion and potentially an edge-to-edge bite. Now, how do we get this patient into treatment is the question. Well, first, we have to understand, now we get to the biology of tooth movement. Because when we talk about pushing teeth or torquing teeth or orthodontic forces, these are based on ligamental compression and tension. So if you are putting that ligamental pressure, if you will, on the coronal part of the tooth, whether you use brackets, whether you use wires of torques and attachments that are put on teeth with using Invisalign and clear aligners, there's a certain number of tension and compression that the PDL does what? It starts to immediately constrict, and the blood vessels then kind of become inflamed. So that's a response to what you see happening in a cytokine family that starts to proliferate out. What does that mean? You're creating pressure, trauma, and that cytokine, the reaction to that push, if you will, that force, allows the bone to move in that osteoclastic, and in the back of the pressure is the osteoblastic activity. This plays a significant role in what we call the osteoclastic genesis through the movements and responses to orthodontic forces. So for instance, if you look at the osteoclasts, as you see the force of the tooth going in the right of your screen, what we're doing now is osteoclastic activity becomes higher, cytokine activity becomes higher. Why we get root resorption is the torque, and then the bone is still rock solid. You don't have that osteoclastic activity. So what ends up happening is you end up getting root resorption because you're pounding against solid bone and you're putting that force. So to remove that, it's ideal to work on the bone. That lateral we talked about now, we need to move that tooth into a position where we have to allow the canine and central incisor to move with it. So the two methods of this pathway in causing what we call now the increase of bone remodeling. Why bone remodeling? You have the osteoclastic, osteoblastic, and this becomes a physical and a chemical activity, if you will, because you can actually be able to induce and create a physical type trauma, allowing this type of inflammatory process. As you all know now, that's what we're heading towards, allowing these precise physical traumatic lesions, if you will, or what we call manual perforations, if you will, versus a chemical one, giving some sort of a chemical reaction. So you now start the pathway of that acceleration or that bone remodeling to create an easier surface for teeth to move. So for physical stimulation of bone remodeling, there are multiple processes. There is what you see coming out potentially with lights and lasers and heat and electric currents, even vibration, have all been suggested on allowing that physical bio-molding of teeth a bone allowing the teeth movements to happen, pressing against the PDL on one side, osteoblastic on the other side, and this consistent push and calculated movements, and in Invisalign's case or in clear aligners case, changing the tray every week allows you to have this consistent force happening. Wire and brackets do the same. Now, in my world, I like the manual. I like the MOPS, as you call it, the manual osteoperforation. It's a lot easier in my world. As a dentist, I'm able to calibrate in putting those minimal invasive pinholes, I like to call them, those small little pricks, allowing this cytokine activity to happen. I know that there's a vibration technique, and there's also, we're going to touch on that today as well. And there's also other techniques coming out, but none of them have been as successful in my hands and that I've seen in allowing that someone like Catherine's case, where now I get her to come in and I'm able to put the attachments on, look at the architecture of the bone, know there's some density there. Those are large prominences of those cuspids. I need those roots to move. And here we are, I quickly put on the perforations, and it's 3 twists, nick right into the bone, come right out. The patient then starts with the aligner. I've created that, if you will, what I call the traumatic event. We started the process of the cellular activity, osteoclastic, osteoblastic, cytokine activity, and sure enough, as we are moving, to me, it's a simpler, safer approach. And not just me, I mean, there's Dr. Alakani, as you know, some of the science that's been there. It's a controlled micro trauma, if you will, without affecting the integrity or the architecture of hard or soft tissue. So we want to create that inflammatory defense mechanism that helps the acceleration of bone remodeling. That's the most important part. So just a one-time scenario allows me to have, in 6 months, I'm able to get the best progress on the anterior aesthetics that she wants. Now I can go back and work on the posterior teeth. Now I can allow myself to kind of, all right, I can breathe a little bit. Look at the prominences of the roots on the cuspids from before to after, and that's in 6 months. Now that cytokine activity only lasts about 3 to 4 months. Those of you who heard me say this before, it's just like, you know, you create that trauma in 3 to 4 months, that's all you got. Now you got to do what? You got to hurry up and get those aligners changed. So some doctors change aligners every 3 days. Some doctors change aligners every 5 days. And the reason for that is to keep that stimuli of the cytokine activity going. And eventually the body starts to repair itself. Says, hey, I've had enough trauma. So now I can go and work on back teeth. As you can see, I can now try to close the bite a little better, cut my aligners, let the teeth settle in, and I can have a much better finish. And I was able to do in 6 months what would typically take me about a year just to get her, hopefully, those lateral position. So if you look at the schematic of the cytokine activity, what you're looking at is the bone and the activation of the bone, allowing that. What I like to tell my patients, you know, it's going to be, we want you to move your teeth in soft, like mud tissue, controlled. And in 4 months, guess what? Things are going to look a lot better. You actually see the best results in 6 weeks. So again, remember, doctors, no anti-inflammatories when you're doing these Propel cases. Tylenol works, and a lot of times patients have no downtime. It's just like they got regular anesthesia when they go through. So when it comes combining treatment, and looking at Megan's case, we want to now control the treatment. The laterals need a veneer. I need to do some movements. Fantastic. Let me go ahead and start with my, as I tell my patients, hey, the first time you're going to see me, I'm going to put some jackets on your teeth. Those are the attachments. The next time you're going to see me, we're going to wake up your bone. We're going to, you know, get the Propel going, and you're going to change the aligner a little bit quicker than normal, maybe 5 days. I'm of the mindset that 5 days is good enough. I know some doctors change it every 3. That's fine. They're trying to get as many aligners in that 3 to 4 month time period. But as you can see, the Propel sites up here, I usually hit them at the attached gingiva level. I very seldom go into the upper root, even though that's ideal. But patients tend to, on the free gingiva and on the vestibular area, bleed a little bit more. Whereas to the attached gingiva, the bleeding stops right away. These are photos are taken right after, and as you can see the progress as we're opening the space in the final restoration, from start to finish, we're just under 4 months. So this allows me to kind of get the architecture to where I need to be, stabilize the bite, and continue with my restorative as planned. So looking at the upper and lower arch independently on the left of your screen, right? We want to be able to upright these teeth. And this particular patient was getting married and was trying to hurry up the process, is what she said. I want to hurry it up. Okay. We were able to get this to her in 3 months, actually just under 4 months. And the bone, as you know, starts to stabilize and becomes even dense. So just like what they say with the teeth, where your bone sometimes breaks, that area become harder and more dense. Well, I've seen that post-propel, the tissue and the gums actually look a lot better in 3 to 4 months and 6 months down the line, a year down the line, of a lot dense and healthier tissue. So these you can see again and again in cases, and as you can see her follow-up, I think this was a year later or so, her follow-up looks fantastic and everything's nice and stable and holds nicely. We want to use this to our advantage. We want to use this type of technology, if you will, because creating that small little bone injury, if you will, and increasing the cytokine activity, you create that bone remodeling and the density drops. And a lot of doctors say, you know what, why do I need this device? Why don't I just use a drill? Or I have other things that make holes. Well, let's talk about that a little bit, because the idea is not just to make a hole for less money. The idea is that you want to have a FDA compliant in your practice, and most importantly, these devices come with a liability insurance from the manufacturer. So if something goes wrong, I've never had a tip break on me. These are end cutting. These are made for spine surgery. I've never had a problem. I used to demo some of these by taking a hammer and try to chisel away the edges and showing how strong they are. But there are a lot of other devices out there that could potentially break, and they're not made for multiple holes. They're not made for you to create that perforation. I'll show you how I do it in a second. They could potentially get dull even after the 3rd or 4th or 5th use. If you see, I'm going from premolar to premolar on my perforations. Using a burr is made to remove decay or to remove bone. So using a burr, you can actually get tissue tag, and you're actually carving out the bone. And I was able to kind of use this example. I have a cone beam. I was going to use this example of showing what it looks like on a patient who's had some of the burrs done with even with a number 2, and it creates an actual removal of bone, and you actually see a defect. You actually creating a bone defect and potential necrosis. Whereas when you're just simply going in and twisting and if you see right here, these are small little perforation. They look like little bee stings. We're just hitting the periosteum part and releasing back. We're not removing bone. So the propel drivers are made not to create scoops, as you can see on some of these cone beams. It's made to just kind of create that little touch of the bone, and if you start to get a real close view of it, you're actually scooping out the bone, versus the driver, you can kind of see you're creating that micro small dimple area. So I was able to kind of do a couple of these different tests on some of my patients who had some perio issues, and I kind of wanted to see what it looks like. I know some of you think might be barbaric, but these teeth were diagnosed to get extracted, so I kind of wanted to have a conversation of whether or not these small little areas, how they perforate versus scooping the bone out. Obviously, you can see in the cone beam here. Looking at the patients that now have these severe type of crowding, severe type of spacing. In this particular case, we're dealing with both. We have a missing premolar, we have a cross bite. This case would typically take me at least 1.5 years to get into position. I now talk to the patient about allowing the teeth and the bone to be moved in wax, if you will, or in mud. And that I have 4 months to do that. Some of you have the ClinCheck 4.0. You can actually use the drop-down menu under the view. You can kind of see it in dual view of before and after. Some of you who like to share this with your patients. But I like using the tool of the tooth movement assessment that shows the blue. These are movements that are outside the aligner parameter. Sometimes they're black. in the 5.0 or the ClinCheck Pro version, you have the little toolbox. You actually drop it in you can take the tooth movement table and take a look at the table of which teeth have heavier movements, as well as you have in your what I call the tooth movement assessment. These are all little views that show the blue or the black of, these are difficult movements for a aligner alone. What other auxiliaries would you like to use? They're kind of telling you that these go outside the parameters of the plastic tray movements. So what are we going to do with these cases? I wanted to open up a little space, potentially try to get this overjet resolved. I didn't want to IPR too much on the lower arch. I have to procline forward, and if you can see that crossbite and that lateral were positioned as the difficult movement, as well as the incisor to come. So in this particular case, I decided to go ahead and use the micro perforation or the manual perforation, osteoperforation. And just simply, you can see these little, everywhere that's an attached gingiva, that's an actual lidocaine. I numb the patient in this particular case. I go premolar to premolar. I'm moving all teeth. I use the device once. I hit the patient once. And it allows me to get that cellular activity moving. It allows me to have that movement of bone. And, you know, in short time, less than 9 months, I'm able to kind of jump the crossbite, put the teeth in position, and I can now, you know, get the bottom locked in and maybe work on the top of what we're going to do here, or kind of get a more cosmetic solution in removing from where the patient was to where they are now. So when you look at some of these cases, I don't think it would have been as easy for me to navigate through without having that bone working with me, without having that remodel of bone. And when we're finished with the case, you can actually see the density of bone is actually greater. So a year later, taking some of these cone beams, you can see back, you know, we followed the patient up a year later in 2016, and that bone is actually dense and solid. It allows us to give a lot of predictability, and we are now kind of pushing the aligner parameters, if you will, in helping with us. So, you know, some of you who know Kevin's case, you've heard me in the Elevate program, I discuss his case, and we talk about his case being a class 3, very dense bone. And, you know, the main objective is how do we fix the anterior, but then we've got to make room for some of the posterior teeth to maybe put an implant. These go outside the parameter of clear aligners. So my biggest concern with cases like this is first patient education, right? You're a class 3, your surgical approach is needed, and this particular patient did not want to have any surgery done. This particular patient main agenda was having a better smile and the chipping of the teeth that's happening on the anteriors, the crossbite on the lateral. I introduced what's called the 2-4-6 rule. So if you have 6 millimeters of crowding or less, these are somewhat of a simpler case. If you have 4 millimeters of overjet on anterior teeth, a little bit simpler case. And if you've got 2 millimeters of midline correction, simpler case. Well, the intrusions and extrusions are about 2 millimeters. Now I have to push in greater than 2 millimeters on each side. When you look at this case, this kind of pushes the parameters a bit. Our crossbite is within the 4. However, the lower crowding is predictable, but the upper rotations and the rotations of the cuspid, that becomes a little problem. So what we're going to do is we're going to try to procline these teeth out and set it up cosmetically first, and then we're going to intrude the upper arch. And looking at just the simple x-ray, I mean, the roots are so long, they're going outside the PA. And the bone is very dense. Using the iTero system of checking the occlusion and the heavy bite on those posterior teeth and anterior teeth with a crossbite. So my agenda was, okay, let's first talk about anterior setup. I want to get this patient in a better coupling. We have to procline these teeth forward. We're going to put some attachments on. We're going to bring the teeth forward, IPR maybe the lower arch, and make the anterior coupling better first. We'll later address the posterior teeth. So first and foremost, patient comes in, put the attachments on, get him some topical on there, numb him up a little bit. I use just the basic infiltration. And the patient now does what? We go right after the attachments that are placed, we start making the perforations. And basically molar to molar in his case, since we're allowing, and if you can see some of these areas, these are tissue tags with the bone. This is my hand just getting tired of twisting. Very dense bone. I usually go about 3 twists, which give me about 3 millimeters. 4 twists give me 4 millimeters. Every twist is about 1 millimeter. But in some of the instances, I had to go a little deeper because he had very dense bone in some of the areas. I go in between the roots, as you all know. And don't worry, you're not going to hit the root. If you do, it's going to be very hard for you to go through the root. So you're going to go at least 4 millimeters plus, because you have about 1 millimeter or 2 of tissue, 1 millimeter or 2 of actual periosteum bone. So you are really going in 2 to 3 millimeters at maximum. Some cases 5. I've never gone beyond 5 millimeters into the bone. So once you see these little small perforations that same day, we then have them rinse out with some disinfectant and chlorhexidine, and the patient then, you can kind of see from an overjet view, we were able to get him here. And just to show you and kind of wow everybody, this is about 3 months of treatment. So we were able to get this patient anteriorly set up in 3 months. We had the patient changing the tray. In this particular case, we had him change it a little faster than the 7-day aligner change. We had him change it about every 5 days. Some cases, patient said, you know what, I felt that there's no pressure, I just changed it after 3 days. So the patient himself was taking a little bit of control out of our hands, and we told him, no, you have to minimally have it in your mouth 3 to 4 days. So we were kind of seeing him back, and we saw that the overjet on the anterior is looking great. Now we can start working on the posterior teeth. We can now tell the trays and the aligners to push these teeth in and create room for implants. So now we're working on posterior teeth. Once the anterior teeth have nice coupling done, we're 6 months into it. We've created one side, and then now we're going to go towards the other side. And I mean, you could see the patient's facial structure start to get a little better. I apologize for the blurry slide, but you know, for us, it just shows that this continuation of patient's occlusion. Once we have the anterior done, we can lock him in and work on the posterior teeth. We can do additional propel if needed. Typically, I recommend just kind of palpitate the tissue, you know, evaluate the X-ray, have the patient rinse with some chlorhexidine. That's just to keep the area. If some of you who put the attachments on or do IPR, you get that tooth dust or the edge around. You know, we don't want to create any unnecessary microbic tissue around the area. So I have them rinse out. Most of the cases I'm anesthetizing. Once in a while I use the profound topical, but I have a hygienist, and in California we're allowed to have our hygienist give local anesthetic. So I have them get numbed up, and I go to town right afterwards. It's very simple. Most patients need one treatment. Anywhere between 20 to 24 aligners, one treatment's enough. If you're doing complex cases with 24 or more, you may need 2 treatments, and there's a 4-month gap in between. So you get about 4 to 6 millimeters of that, what I like to call the cellular activity. So usually 1 or 2 small perforations are needed. And it lasts anywhere between 10 to 12 weeks, which is that 3 to 4 months time. And if you have a complex case of more aligners, then you can decide if you need to do more. And most of the time, 99% of the time, I'm usually using 1 of the propel. Where I perforate is obviously right in between the roots. If I'm missing the bicuspids, I'm hitting mesial of the molar. In this case, if I have both bicuspids in and I'm moving posterior teeth, I go mesial to the molar. Typically, I don't do much on the first and second molars, other than uprighting, and the aligner's able to do that up to 2 millimeters or 20 degrees. So when you look at these areas and you look at the perforation, that's the lidocaine shot right here. That's not a perforation. That's to get the patient numb. But when you look at it, I'm kind of going to that where the attached gingiva is, right in between the attached gingiva, and kind of make sure that that reduces the patient's bleeding. And you can actually plan this on your clin check. You can actually plan anterior and posterior teeth where you want to go. Again, very seldom do I go 5 millimeters of perforation. A lot of times I've heard doctors, they say they do this L technique or the 3 or the 1. Look, my theory is wherever there's attached gingiva, that's where I hit it. Some areas get 1 perforation, some areas get 2 perforations. So wherever there's attached gingiva, that's where I'm perforating. So there's no real formula for me as to where I'm going, but it's anywhere between 3 to 7 millimeters I very seldom have used 7 millimeters. I'm typically at that 3 twists, which gives me the 3 millimeters. There is 2 different types of devices. The reusable handle, which some of you doctors know about. That's the one that's my go-to. I just kind of press the little button, dump the handle in my sharp instrument, and then ready for the next patient when it's disinfected the handle. So there's also the other single-use device, which has a little light to it, and it has a little.
I like to propose.
I'll kind of show you.
Already accepted. I always like to show the patient that we are taking.
Sorry. So in this particular case, Nadia, who happens to be my assistant, she had areas of root rotations that I needed to do. And those of you who have kind of seen this, I want to kind of show you how the single use is. It has a little light at the end. And if you kind of see where I'm placing it, right in between the roots, I put my index finger at the end, and my middle and thumb do the twist. And this typically a few twists, 1 or 2, maximum 3 twists. The light turns on, that's about 3 millimeters, and you bring right back. So it's a very simple process, but I know those of you who are not yet used to it and haven't seen it, it kind of looks, oh my God, it's difficult, but it isn't. There's also a handle that is a, what we call a power driver, and these actually have little tips that you can use. Either you can have your own power driver, or Propel provides you with one. I think they sell some of these as well. Just know that it's a one-time use. These, you cannot sterilize these because A, it melts, and 2, you end up having bone tissue there that could become a problem in the sterilization. So it's a one-time use. Most of these drivers, the accelerator, as you can see, the RT is the one that's the PT, the power driver, is actually easier than the twist on your wrist. So I've now moved and integrated towards the more of the power driver, and it allows me to kind of go in, and you can kind of see it forwards, and it, once you tug the bone, you feel it, and you reverse out, and you can take it right out of the tissue. Patients typically feel nothing other than a little pressure. Again, we're not going through and through, we're just going in just about 1 millimeter in the periosteum area. So that kind of gives us the idea of power drivers creating the manual osteoperforation that I'm happy with. And when you start to combine these treatments, now it's kind of fun. Because when I get to see that lateral, and I know for a fact that this number 10 is going to have a hard time without any kind of rubber banding, any kind of elastic. And it's a peg lateral, somewhat of a peg lateral, with a small lateral. But I want to make room for my aligners. Patients already coming in with a posterior light butt on one side. I need to get that bite resolved. And when you start to look at this case, in talking to my patient, it's a lot easier conversation to say, hey, part of your treatment is that we have to include this type of work process. And I'll kind of go through how we do our fees and setup. So there's no question of my, whether or not I believe the product works in my practice. I know it works. I'm confident that I'm going to use these mops, use these perforations to my advantage, get the patient to change the tray. Now the patient's changing the tray, not just accelerated, but more predictable movement. And I can actually get this patient into my restorative treatment plan and do it all seamlessly while I'm now going to be working on the posterior teeth and at least the anterior couplings done. In a lot of my cases, you're going to notice that I try to get that 1 millimeter overjet overbite complete. That's the actual restorative put in. That's a temporary provisional put in, while we're going to work on the back teeth, because I get to show the ClinCheck software where the anterior teeth I want it to land. Now, again, I want to do an IPR, land the posterior teeth, kind of move to the next level of getting that 4 months, all the heavy movements out of the way. That's my agenda. When you start to look at the patient's laterals, look where the roots were. I mean, how are you going to upright that root without allowing the bone to kind of work with you? That's the lateral. Look at 7 and 10. Look at where the roots are. Very difficult in just relying on either rubber banding or just clear aligners by themselves. So, you know, it's wedged in, as I mentioned to you, that lateral in between the incisor and the cuspid. And that becomes a problem for us. Using the technique, obviously with Propel, you can actually now see where the patient's teeth were. And a lot of you who are able to kind of do cross sections on your cone beam, you can actually see, all right, well, that's the area, how much bone we have, and the you have the periosteum, the trabecular bone is right here, the roots. And then as you kind of move, you kind of see the spacing happening. You actually see things happening, and that's a short amount of time. You're actually moving teeth, and creating this cross section allows me to, I don't cone beam every patient 6 months. In his particular case, we had a tooth that was kind of changing color on us, and I don't know if you guys kind of noticed on the slide earlier, right here. Let's take a look here. If you notice that bicuspid, I was worried about some sort of an internal problem that we're having. It was just an internal discoloration. I was nervous about it, so as I kind of go through, and now I'm able to actually see my cross sections as well. So the only reason that this patient had a cone beam was because of follow-up of that root. But it gives me an idea of how these teeth are moving. And those of you who know about bone density and use the Hounsfield units, you can actually see that in such a short time, we are actually moving these teeth without resorption. Bone is actually not as dense or as thick, if you will. So we're able to kind of do these measurements, and it's kind of fun, those of you who are able to take this to the next level with your orthodontic practice in the GP world, of kind of seeing the roots, and you're seeing all these movements happen, and the bone density that changes as you go through. Now, we're going to introduce to you what you see here on the slide, which is the vPro 5. I'm going to kind of introduce to you about vibration in a second and how I use that in my practice. But I kind of want to follow through and finish off the idea of what it looks like, those of you week 1, week 2, and by week 3, the holes have completely closed and the patient's towards healing. But again, the cytokine activity is going to last that 4-month time period. So you're able to remove these teeth a little bit quicker. So I want to kind of get to the next conversation of talking about aligner seaters and vibration and how I'm able to use this in my practice for some of those compliance issues. I mean, it is very easy to tell patients, hey, change a tray every week, wear it 22 hours. Them doing it, it's a whole different story. Remember, we talked about the other patient factor of following instructions. So what happens to some of these patients who have had either Propel or who've had some sort of treatment, but then they slack off? Or some patients that didn't need the Propel. There's such a small movement. Some of your Invisalign Express cases. So I'm able to now use the software. I'm able to use the vPro 5, which is an aligner seater that helps. It's much better than I call Chewies. Why? Because you're able to kind of vibrate this aligner and allow the teeth to just move into position of the aligners and lock themselves in. So let's talk about Makai's case. Some of you who have seen this case, you see that the lower incisal third, the aligner is not fitted well. He was a class 3, and he just is not a compliant patient. He told me he wouldn't wear it when he goes out. He does a lot of events, and actually, Makai, you might have seen him in one of the movies that's was just recently out, and Straight Outta Compton. He was one of the folks that he didn't wear his aligner throughout the whole movie shooting. I said, well, no one could see it. He says, I'm gonna lisp, and I said, no kidding. Look how the aligners are actually not fitted well because you don't wear it all the time. Now we have a couple options. Either we have to go and kind of take attachments off and reboot him, or I can give him maybe interproximate, maybe IPR him. You know, in this particular case, I just didn't think I needed to propel him and do the mops. And you know, when I put the Chewies on, when the force was applied, it stayed. As soon as they took the Chewy off, I went back to looking like the space that we had between aligner and tooth. So it was very difficult for me to get these aligners to seat. And when I introduced the vPro to him, it allowed the aligner 5 minutes a day, vibrates and has different oscillations. The patient just simply puts it in their mouth and it does its own cycle. And the aligner then just seats and locks itself into the teeth. And why? Once you create the amount of right spaces interproximally, now I don't have to go back and reorder aligners, but instead the existing aligner he has are going to have a better fit, grab the tooth, and move into position. So I don't necessarily use the V-Pro for acceleration, if you will, but think about it. If the aligner's fitting better and the patient goes back and changing it every week like they're supposed to, you're already on track. That could potentially help you accelerate the treatment. So in my world, I use the aligner seater or the V-Pro 5 to help engage the aligner and tooth and make that engagement continue for their treatment. A little bit better than having that plastic chewy bounce around their mouth. If it's 1 to 2 millimeters, very easy. If it's 3 to 4 millimeters, a little bit more difficult. But beyond 4 millimeters of spacing between tooth and tray, I'm now taking a new scan or impression of the patient. Some of you may have a iTero scanner or a PVS. Send it in, and I reboot the case. So typically, my cutoff point is if it's beyond 3 to 4 millimeters, then I'm going ahead and moving forward with a new impression and new ClinCheck. But I can easily seat up to 3 to 4 millimeters of tray using the V-Pro. Okay, so the patient's experience have been great. I mean, I've even used this for mixed dentition. I've used it for, in this particular case, the patient has a cuspid that's a deciduous tooth, and I've used it where allowing the deciduous tooth to also fit. We weren't trying to move it. We're trying to keep the deciduous tooth where it is. We're trying to move the other teeth around it. So as you can see, the V-Pro is not touching the deciduous tooth. However, it is allowing the tray to seat, and we're able to get these teeth in much better position and continue the treatment without having to use any kind of propel. This patient was pregnant and she was nervous, so we were able to hand her a propel device, which a little bit easier. I'm sorry, a V-Pro device, a little bit easier. And again, I still follow up with a lot of cone beam technology on some of these patients. This was post-treatment, so where we scanned her, so it wasn't after her pregnancy, when she was done. And we are able to now have this as part of our treatment in our practice. So the fees then reflect whether we include it as any time of 12-month, 18-month, or 16-month treatment, or in some cases it's a standalone extra $500 charge, and we just kind of put that, package it in, and always say, look, the retainers then at that point are, we use the Vivera or some other retainer options that are going to be at an expense, because I don't think patients understand that retainers, they need to replace them every 3 to 5 years, and there's no value for it. So I'd rather put some pricing on retainers rather than trying to make the propel or any V-Pro as, oh my God, this is an extra expense, do you want it or not? No, it's part of the treatment. So some of you in fees that you charge, I kind of put an entire revenue process for you of what you save, and this has been kind of the picture that I paint for doctors who do anywhere from $4,800, $5,200 to $4,500 some of your cases, and that actual chair time. I always like to finish in 5 visits. I tell my patients every 5 weeks I will see you. You're going to change a tray, between 5 to 7 days, and in 20 weeks we like to be done. That's 20 aligners. So the propel kind of becomes a must in my practice. The rest is stabilization, allowing the posterior teeth to settle in, and the rest is just kind of allowing the full occlusion to come into play. So I'm telling my patients about what I call a tier level, or whether you're an advanced case or moderate case, where the propel could be part of your fee, or it could be a standalone. My advice to you doctors and team members is not to make it a standalone, because patients then don't have value for it. So if you're greater than $6 million pricing, you're this, you're less this, and that what that tells you is if your teeth are overlapping, you're more of a difficult case, you have a higher price. If you are moderate or less of a crowding, overlapping, you have a lesser price. And when it gets to insurance billing, you only have one price. But if you want to add a propel to this, the way I would do it is to typically tell the patient, look, here's our fee for our moderate case. And it's going to be about $500 a quadrant. We're only going to charge you $500, that's it. Even though we're supposed to charge you $500 a quadrant, that includes the entire mouth, You're basically paying for the device itself. And just so you know, I purchased the device anywhere between $120 to $140. So, you know, I always like to bump it a few hundred, so that way it pays for my time as well, even though you're saving some time. Some dental insurances cover retainers and orthodontic. Some other insurances may or may not cover that osteoperforation, which is the alveoplasty with non-extraction of teeth. But either way, I'm happy to give them a discount if they start today. So if you look at it, the insurance is the orthodontic insurance, no problem. But this $500 that I reduced, you see how I have the Propel and the retainer fee. So it ends up, they're really paying for one of these, either the retainer or the Propel. I'm giving them a discount today if they start. Some patients have flex paying, some patients don't, and there's your out-of-pocket expense. So, and if the patient didn't have that ortho insurance, then you'd add the $1,500 here. So typically, my orthodontic pricing with no insurance hits them at that 5,000 plus mark. Or if you end up having this start today and the insurance covers it, you're in that 4,000 price mark. So it kind of helps. I use my merchant processing to my advantage. And those of you who keep asking about how do I get this done, I've kind of given you some tips and tools in getting the patients on the payments. I'm fine with those. I've partnered with companies that have helped me, just like Propel, in kind of bringing that tools and management skills that I'm trying to get my front office to become and do. So a lot of times, orthodontists especially, they are allowing patients to make monthly payments. Well, we don't as GPs. We say, it's $5,000, how do you want to pay for that? Cash or credit? Well, I don't mind allowing patients to continue their services with me and pay me monthly once I have the right partner to do so. So I've given you some options there that you can actually call in. That's on Ataii.com and the number I put, so for you to be able to help your patients into treatment monthly. Propel does a great job in marketing. I mean, last time we talked about this, they have brochures and templates, and you know, I talked about referral and then the 4 Ps, the last webinar. Those of you who saw about the product, and in my world, I'm very happy using these as tools for my patients. That this is a product that helps them with their orthodontic treatment. They see nice smiles, everything's happy. Who wants to take 2 years for their treatment? Nobody. Nobody wants to do that. That's one of the reasons why they don't even come to your practice, because it takes too long. So, you know, I'm happy to partner with a company that has different dimensions of not just helping me with the process of making clear aligners easier, but those of you who have access to the orthodontic practice, I just saw that Propel actually is promoting some of their products, and I looked over, and right next to it, I'm talking about, I have a continuing education in the Ortho magazine, and talking about some of the multi-dentistry that I do, whether it's sleep or crown. Propel becomes a fundamental role in getting these teeth in the right position. So again, it plays a role in any and all tooth movement practices, and it's great for those of you who kind of attended this and trying to get more education. I've given you some tips and some sites that you can go on, but what I want to do is just allow to kind of open some questions and see how often we can kind of revisit each other. So I'm going to open up some questions for everyone, and let me take a look at the first one. We've got one from, okay, I can't pronounce your name, but Nasty. How do you decide what intervals to change aligners after Propel? Okay, that's a great question. How I decide is a little bit difficult, because what ends up happening is that you're taking a look at the case. I'm going to just flip over to this case here. A lot of times when you're trying to decide how often they should change the trays, you have to talk to your front office as well. Your front office is going to say, hey, when do I see this patient back? I have the 5-week rule. So I give my patients 5 aligners. I see them in 5 weeks. So that gives you 1 week tray change, right? So on average, I'm sticking to my 7-day change. And if a patient's getting married, they have an event or something is going on, and their bone isn't as thick as what you saw earlier in Kevin's case, then what I'm doing is I can say, look, I'll go as early as 5 days, okay? I can go as early as 5 days. I know a few orthodontists and I know a few doctors that actually do 3 days change. I have not done the 3-day change. Kevin's case, he did. Some of the trays he wore 3 days, some of the trays he wore 5 days. And the reality is there's no root resorption because the bone in that 3 to 4 month time period is kind of like Jello, at best I could put it. So the reality is, in my office, I don't have them change it less than 5 days, unless if the patient is really antsy and they're getting married. I say, you know what, let's try it. Let's see how we do. I've done that to probably about a handful of patients, maybe 5 to 10 patients. Most of my patients are 5 or 7 day. My goal in Propel is that predictability, getting these difficult cases to line up nicer. So follow-up question, do you Propel on the palatal? I have not. I'm not brave. I have not propelled on the palatal. I'm not that brave yet. That greater palatine nerve makes me nervous. I have not been that brave yet. But what I can do is let you know that I know Dr. Shipley and a few other doctors have to do the mandible area as well as the palatal area. I'm not that brave. I have not. I think it's good enough up to where I'm at. Dr. Levine, what change intervals do you use if Propel is not used? In this line saying 7 day is fine with no acceleration. Yes, so Align's view is use your best judgment. As a company, we can't tell you 7 or 10 day or 20 or 12 or 14 day. However, their research have shown that 7 day is effective. So as a company view, they've always put it in our hands as clinicians. However, they're saying, look, we've done 4 million aligners and we feel strong enough that every 7 days work. Is that a black and white with everybody? No. If you've got dense bone or some of the long roots, you may need a little longer. I don't know if adding longer is the right way of doing it. What Align is trying to say is just because you're weighing the tray longer doesn't mean that the tooth is catching up to the movement. Why? Because the science that we know of that cellular activity, you want constant movement, force, time, and pressure to be consistent. And they want that to be every 7 days, not the 14-day traditional use. So again, in my world, whether you use Propel or not, 7 day is something that Align is pushing and showing that it's effective. My goal is tracking. You can have the patient change every 7 days, but what happens if they don't track? What happens if you end up having these spaces between the teeth? Now what are you going to do? You're going to keep changing aligners and asking for a new set and a new clean check every time. So my stance is that I'm any teeth that are 4 millimeters of crowding or more, any teeth that have any kind of extrusions greater than 2 millimeters, I'm propelling them. And that kind of is almost the bulk of my patients who need clear aligner treatments. So next question, what change interval? If you clean check is poor design, Propel is useful. They're saying if your clean check is not of the best outcome, is it gonna help? So I guess what I'm understanding from your question is that if the clean check is of poor design, is Propel useful? My opinion is, yeah, I mean, if let's say your clean check is saying your tooth is this blue movement and it comes all the way out. Well, without Propel, I don't think I would have been able to get that lateral out of crossbite. Without Propel, I don't think I would have been able to get to where I'm at in working on the bone. So the clean check is a visualization, is a virtual movement, in my world, I use it as a guide, not necessarily as a tool that, oh, of course my teeth are going to end up there. Because I'm dealing with bone. I got to work on bone. And that's the key. So if you check, okay, do you ever use Propel on the molar or close to? No, I don't. I very seldom hit the molars. I put mesial of the molars. So let's say, for instance, you're planning an implant. And last webinar, you saw I did an implant case where the implant was on number 20. So I don't get anywhere between 6 to 10 millimeters of an implant or an area that I want the bone to be very dense at. So typically on molars, we're just uprighting, so I hit the mesial. If you have a missing tooth or an implant that you're planning on working, I do not hit the mesial or distal. I'm within 10 millimeters away from that implant site, if that helps answer that question. If the root is too long, do you propel beyond the attached gingiva? Yeah, so if the root is very long, do I propel? So the answer is, in Kevin's case, I don't know if you can see. Can you see the roots going all the way up and beyond my photo? And look and see where I propelled him, okay? Let's go see here. I kind of tried to go as high up, and you see that? I hit him 3. So I went beyond the attached gingiva. The only reason why I'm not happy with the vestibular area, because they bleed. Can you see that they bleed? And the bleeding is only a few minutes. So rinsing out with the chlorhexidine helps. It's just that in this particular case, I had explained the patient perfectly, and I didn't mind going beyond the attached gingiva. I had to. So the answer is yes, I have to go beyond the attached gingiva if the roots are long. I prefer not to, because of the patients wondering, oh my God, why is my mouth full of blood? So we try to rinse them out right away, and within a minute or two, as long as they're on an aspirin treatment, any kind of blood thinners, we're good. The bleeding is stopped. If the patient has localized bone loss, is propel contraindicated? Does propel cause tooth mobility? Yeah, okay, so remember, propel is causing the cellular activity to increase from that inflammatory sites. So what propel is doing is making that bone remodel happen faster as you're tearing up the new old ligaments, and new ligaments are going to form. So yes, you're going to create a little bit of mobility, but once you stabilize and stop the movements in proper occlusion, then what ends up happening is bone gets hard. So you want teeth to be mobile during orthodontic movements. That's a fact. I don't want them to come out of the socket. I want Sharpie's fibers to attach themselves. But the reality is, you're going to have to create that area of density to go away and mobility to happen. Otherwise, your teeth won't move during the time of orthodontics. Now, if the patient has localized bone loss, I'll tell you what I've done in some of these cases. And I think Sam's case had a little bit of bone loss. That wasn't his case. Let me show you. I don't know if you can see, but he had a little bit of localized, not much, but he had a little bit in between this area. But I'm not a fan of hitting them on the area of periodontal, active periodontal problems. I don't hit them, and I don't ortho them. I make sure that I have a perio clearance. I've had patients that I've propelled on 1 or 2 teeth that have had maybe 4 or 6 millimeters of pocketing, but the pocket's been reduced. You know, they're on. You know, they're not active periodontal. They're not bleeding all the time. So that's 1 or 2 times that I've done it. But typically with localized periodontal bone loss, I'm not hitting. As long as you are in attached gingiva, you will avoid the mental nerve. Okay. So I guess one of the doctors, Dr. Asar, is answering, I think, the question about the palatal. I'm guessing you might be answering the palatal information. As long as you're in the attached gingiva, you'll avoid the mental nerve. So remember, the mental nerve is down here on the lower bicuspid, so that's why I'm not going into the vestibular area. And Dr. Asar, I hope I'm pronouncing your name right. You're absolutely right. As long as you're in attached gingiva, you're going to avoid any nerve damage. In the palatal area, I don't know. I don't know what to tell you about that one. But in the buccal area, I 100% agree. As long as you're hitting the attached gingiva and you don't go too far down the vestibular, and again, you're only going 3 millimeters. It's just like you kind of doing that perio probe. You're not going beyond that in some of these areas. You're going to avoid the mental nerve. And I will take the final question. If you have implant near the tooth for propel, how do you do it? Yes, so answer that question again. If there was an implant here, I would avoid 6 to 10 millimeters away from the implant area. We know that each one of these little small dimples allow us anywhere between 6 to 10 millimeters of cellular activity. So if you have an implant, I want to avoid the mesial and distal propel sites anywhere between 6 and, in my world, I say 10 millimeters. Okay, so I know some of you still have some questions coming through. I will give you my email and my contact information. Those of you who want to reach out to me at drataii.com, go ahead and do so. To receive your CE, you're going to have to take that little quiz, and I will forward that over to our lovely folks at Propel for you to get your CE units. And if you have any other question, please email me. I hope you found this session informative. As always, I try to give you cases, and sometimes some of these may be redundant in nature, but learning is always great. So thank you very much, everyone. Have a great rest of your evening.